Hello, everyone. Welcome to this joint Consumer Voice and National Long-Term Care Ombudsman Resource Center webinar regarding the role of the Ombudsman program in nursing facility closures. We're so happy to have so many of you joining in today's webinar. Just some housekeeping. This webinar is being recorded, and so if you registered, you will get an email that has the recording. The recording will also be posted on the NORC and the Consumer Voice websites, along with the PowerPoints. Please use the Q&A feature for questions and the chat feature to speak with each other. We may or may not be keeping up with all of the chat. So if you have a question, please put those in the Q&A feature. And if you're asking questions, then you're asking questions of other participants and people that have signed up for this webinar. At the end of the webinar, when we close out, the next screen that will come up will be an evaluation, and we would very much appreciate it if you would take the 20 seconds it takes to answer just a few questions about the webinar. That helps us present the best material and have a successful educational opportunity. So please let us know what you thought. And then the resources and the webinar recording and the PowerPoints will be posted again to both the Consumer Voice and the NORC website. Our speakers today, Amanda Hamilton is a 2012 graduate of Miami University with a bachelor's degree in gerontology and has been a certified ombudsman since 2018. She serves the FIVCO. I don't know, is that, there must be some way to just say that. Is it FIVCO? FIVCO district in Kentucky, which includes 6 counties. Her program is within legal aid of the Bluegrass, a legal services provider that provides services to low-income individuals. Pam Railsback has been with the Ombudsman program, has been with the long-term care world for almost 25 years. After almost a decade in the nursing home social services department, she joined the Ombudsman office in 2007. And she says that ever since, she still learns something new every day and enjoys the difference she's able to make for the residents and tenants that she serves. Excuse me. Our next speaker is Lori Smetanka. Lori is the executive director of Consumer Voice. She's been in that position, oh my gosh, for like since 2016. And before that, she was the director of the National Ombudsman Resource Center. Lori is an attorney and a super great advocate for residents, families, staff, all in an effort to get the best possible care. And my name is Carol Scott. I am the manager of the Long-Term Care Ombudsman Program and Policy at the Ombudsman Resource Center. I've been here for 8 years. And before that, I was the Missouri State Ombudsman. So that's who we are. And we've got our information on here. We will be actually, Katie, could you put the link to the PowerPoint in if you haven't already? I neglected to copy that before I did it. So today's topic is about nursing home closures. And, this is not necessarily a new topic. There's always been facilities that have closed, but it just seems that in the past few years, there's been more and more of the closures, whether it's been because of the weather or a fire, but more and more facilities are voluntarily closing, in addition to those that have issues with staffing or funding or whatever. So one of the things that we noticed that it's making the headlines, and it's occurring across the country. It's not just one state. So we thought that this topic, it's very timely right now. We know that 135 nursing facilities closed in 2020. We know that there's been more than 1,000 nursing homes that have closed since 2015. 300 of those, 327 of those were during the pandemic. And that we know that since from 2015 to 2022, nearly 45,000 nursing home residents have been displaced due to closures. So timely topic, and we hope that something within this webinar helps you as you are helping the residents. I'm going to turn it over now to Amanda Hamilton. Amanda?
Hi, good afternoon. So I am speaking today about a facility closure I experienced at the beginning of last year. I did want to explain that this closure was actually a personal care home, not a nursing facility, and that this closure was considered a voluntary closure. So when I say voluntary closure, I use that term very loosely because my facility closed due to the city filing eminent domain, which is the process in which the government seizes private property without the consent of the owner. And the facility and the residents tried to fight this seizure, but ultimately they were unsuccessful. So when I say voluntary closure, that sounds like it would be easy, especially since I had other local facilities who had saved some beds for these residents, knowing that this was a possible outcome. But that was not the case. Many of my residents, they were in a personal care home because they suffer mental health challenges. And most, if not all of them, were in the facility on a program called state supplementation, which allows them to have the income they need to stay in the facility and receive services, even though they don't actually make enough income. So as you can imagine, with this type of payment, there are just not a lot of beds available in the state that would offer this. And many of the beds that were available were very far away. To relate this back to the nursing home world and nursing home closure, it makes me think when I've worked with other ombudsmen in other areas that they've had a resident who they have a bed that's being paid for by the VA. And, that type of payment is only accepted at certain facilities. So they have to go to a facility that accepts that type of payment. At that time in January 2022, there were not very many facilities that could take these people. COVID regulations were very different than they were now. And, it was January, it's the winter. It was a peak time of COVID outbreaks. So when it came time to do these placements, many of the facilities could not take them, and like any other closure, the facility lost a lot of staff because it's difficult to get people to stay knowing that they're about to be out of a job. At the end of my closure, I believe the facility only had one person left working, staying with these people. And the other problem when you have a facility closing is there's cash flow issues. So, when you're in the last days of this type of closure, that the facility, they're not going on, they've given up their license. That's the time when it's, are they going to be able to keep the lights on until we get everybody out? Are they going to be able to keep the heat on? Are they going to be able to pay this gas bill to keep the kitchen going? And earlier, I briefly mentioned mental health, but I feel like this is a big pillar in these issues. The situation itself was very taxing on someone's mental health. Coming out of the pandemic, we were all struggling with some kind of trauma, but the residents were particularly impacted in all of our facilities. They had been stuck inside due to COVID regulations. And, we talk so much about transfer trauma and the very severe impacts of it. But, during COVID, so many people were moved around in the facilities without notice. And, there was just all these struggles that they were having. So then you add to that struggle the place that you consider a home is being taken away. Many of these residents had been there a long time. This was the only home and the only family that they'd known. And, many of my residents, they were part of this fight with the eminent domain. They wanted to go out and speak and be part of these protests. And so they really struggled with grappling, why am I not wanted in this community that I consider my home? And, just struggling with the fact of the facility was closing and they had to go somewhere else. They're struggling with adapting to change. Um, so then you have all these issues, and this is leading people to go into crisis or to go to the hospital or to have some kind of behavioral issue. And that kind of thing makes it difficult when they're looking for placement because they're sending these packets to other facilities. And then, to add to kind of this perfect storm of mental health that we had going on at this time, um, we had the local hospital that had an inpatient behavioral health unit that my residents could go there and, have their medications adjusted or, in some way help, get them back to being stable. Um, they closed because we actually had one of our local hospitals closed during a pandemic. And so, in addition to the various impacts of losing that hospital, many people that were in a crisis state or had something going on, they had to go to the state mental health hospital. So you think at this time we're trying to find these people beds, and they're sending these referral packets. There's a very big difference. It's for a long-term care resident. If you saw that 7 times in the last year they had been to the local hospital, which is, where they were able to go to this unit. That's not a big deal. 7 times going to the hospital is nothing for someone in long-term care. But when these new facilities we're seeing with no context that this person had to be sent out multiple times in the last year to the state mental health hospital, they perceived this as, someone that was above the level of care they can provide or that they wouldn't be able to take them. So this prevented a lot of people from getting these referrals. So with all this said, I did want to say this story did ultimately have a sort of a happy ending ultimately because every resident did find placement, though many of them did have to move very far away. I was very fortunate to have so much support and, circling back, I think it's wonderful that in other types of closures, there are teams that come in and help. I feel like many of the issues that I had in my closure would have been avoided just having these people coming in and assisting on site every day. I had, there were issues with some of my residents, they had belongings in a storage unit that, many of them are still wanting to get their things. And, having myself as the only person on site every day, we're limited as ombudsman of what we can do. And my best advice to people, going through a similar thing or just, in general, I think it's important that we know our community partners and our community resources, and we know how to ask for help and when to ask for help. I think as advocates, we often pour far too much from ourselves before we're able to ask for help. And I was so thankful for the support I had. I had a couple of district ombudsmen that actually helped me. I had residents that wanted to go to one of their regions because that was where they were from. And they actually, contacted me with some beds available for the facility. That facility actually ended up taking my final 5 residents who couldn't find placement anywhere. Within my organization, I have other certified ombudsmen that I work with. And at the time, I had an ombudsman assistant working with me. And they were a wonderful resource just to help me because during this time, we had to be on site every single day. And, also within the organization that I work for, there are so many resources for these people to help, to get them back on their feet and to help that, that they're low income or that they are wanting to, find some other type of placement. I also had several community partners that I work with regularly that were really great to help me enroll individuals in their organization's programs. And this helped keep them from being homeless or, having this worst possible outcome. In Kentucky, we have a state ombudsman or a state guardianship program. I'm sorry. And the state guardians were wonderful to work with. They worked with me constantly to make sure that these people had what they needed. When you're in a personal care home, like a nursing home, you have this personal needs allowance. They receive $60 a month. And they didn't really have the ability or the capability to plan for this upcoming move. In addition to it being short notice, they have very little money. So how are they going to transport themselves 5 hours away and transport their belongings? I had the state guardian helped with moving several people 5 hours away that it would not have been possible without them having a way of transportation. So I think that was the biggest help, was that we had these resources. That covers all of my information that I had for this.
Okay. Great. Thank you so much, Amanda. We appreciate that very much. So one of the nice things about most nursing homes is that there is federal guidance, federal mandates, federal law, federal regulations. And one of the areas that is covered by the federal government is the closures of facilities. The Centers for Medicare and Medicaid, CMS, required that there be a written notice and that of a closure, and that a copy of that written notice be sent to, among other people and other programs, to the state long-term care ombudsman, in addition to residents and their representatives, and that be sent out at least 60 days in advance. Facilities must have submitted a plan to the state survey agency, and the state survey agency is to approve or require modifications to that plan. And that included in that plan is the assurance that residents will be transferred to the most appropriate facility, and that the facility is not allowed to admit any new residents. One of the reasons it's important that ombudsmen know what the requirements are is to be able to hold facilities and the state survey agency accountable. So it's very important that we kind of go over why, what the federal requirements are. And so knowing that there's supposed to be a 60-day notice, knowing that who all is supposed to be notified, knowing what the notice must include, is very important, because that's a beginning of a conversation. And I will say that most ombudsmen who have worked on a closure can tell you that at least at some point something doesn't go according to the plan. The closure plan is also to take into account what day is the facility planning on closing, and what are they doing to ensure that there will be staff available, that there will be food and clean laundry, and all the other parts of running the operation up until the day that all residents have been successfully relocated. That includes the labeling and safekeeping and appropriate transfer of residents' belongings. And as an ombudsman, to get a copy of that closure plan from your state ombudsman, to know what that plan is, and to be able to ask questions when you're in the facility, and to alert people if there's something that's not happening. If you're in a facility and you see that that the staffing has really dropped off, and that you're hearing that people have left and taken other jobs, you may be the person who's kind of shouting out, hey, somebody needs to come and look at this facility. And there needs to be sufficient preparation for a safe and orderly move. The survey agency and the ombudsman from time to time should be talking to residents and their representatives to see where they would like to move to, and to make sure that that information is passed on. It's not the ombudsman's role to help someone pack or whatever, but it is the role to make sure that that if the facility has a plan that's been approved by the state, that in fact that they are following that plan. So what Consumer Voice and the Ombudsman Resource Center, NORC, we have done is we have developed a brand new resource guide, a reference guide that is all about the role of the long-term care ombudsman in nursing facility closures. This was put on to our website today, but you can see in the slides when you download them from the chat, you can click on this link and it will take you to that new document. I highly encourage that you read this, pass it on to others in your office that might not be a part of this webinar, and that you read what the appropriate role of the ombudsman is. One of the things that we mentioned in that reference guide is transfer trauma. We all know that when people are not the one, I mean, sometimes even if you're the one making the decision to move, it can still be traumatic. If in fact you are someone living with dementia, we know that routine is very, very important. And so getting someone out of that routine by putting them in a vehicle and taking them to a strange place and saying, this is now your home and this is your room, and can be very traumatic. Even for people who don't have dementia, it is, you're unsettling. And Amanda mentioned people moving hours away. So maybe your friends and family can no longer visit. So the Resource Center has a trauma-informed issues page. Highly recommend that you go there and look at it. And then we have a resource just like the one that we're talking about on trauma-informed care. So this might be a good opportunity to do an in-service for your ombudsman volunteers and other staff regarding transfer trauma and trauma-informed care. In this resource guide, we do have separated out actions that state ombudsman can take and actions that ombudsman representatives, staff, local staff, regional staff, and volunteers can do. The most important thing would be to create policies and procedures. What is the state ombudsman expect of the program? How will they be working with other units in state government and in local governments? Is there a relocation team? And Lori's going to be mentioning some of these things also, which is always good because it just shows the importance of it. But having a relocation team that's made up of the state survey agency and other agencies within state government and outside that might be able to assist can go a long way to making sure that there are multiple eyes and ears within the facility and prepared to help residents. If possible, to identify and train someone within the state office to serve as the relocation specialist. There are a couple of states that actually have a relocation specialist, and They are a part of the relocations team. They're assisting the local programs when there's a closure in their area. And then to develop an in-service training that can be used by your representatives for not only preparing residents, but also maybe talking to family members and to staff. Developing educational materials regarding identifying, preventing, and minimizing transfer trauma, to advocate that the facility remain open until all the residents have been relocated. And then maybe, if necessary, trying to meet with people to see whether or not a temporary manager or a receiver could be installed so that maybe the nursing home doesn't have to close and residents wouldn't necessarily have to move. And then to have lots of conversations with maybe the state employment agency to see if they are aware of other jobs that maybe some of the staff might be able to take advantage of as they are forced to no longer work at the particular facility. For Ombudsman program representatives, staff, and volunteers to be, when you visit a facility, to be looking for warning signs that maybe something's not happening, that there's not funding, that there's other rumors or whatever, that the facility's doors are maybe going to be closing, and then having that conversation with your state ombudsman to maybe be able to be asking the question, excuse me, and not have it become a surprise that a facility is closing. To meet one-on-one with individual residents throughout the process, and to talk about what their rights are, to tell maybe what the plan is that the facility has made, and to discuss their discharge plan, what they want, where they want to go. To create opportunities for regular updates for residents and families and staff. When you're in the building, it's maybe hosting a family council or family group meeting, a resident group meeting, and creating an opportunity for residents and families to ask questions of the management if there's confusion. Then communicate regularly with the partners, the state survey agency, the Medicaid program, Money Follows the Person, protection and advocacy. The more the people in your area, the easier it's going to be for you to pick up the phone and say, hey, I this particular resident needs this, and I think you might be able to help them with that. To share information about how to prevent or minimize transfer trauma, provide in-service training for staff, facilitate a group meeting, encourage the closing facility administration to assist their staff with future employment, and then to follow up. Amanda mentioned that she was in touch with her colleagues in other areas of the state, and this will be very important as people move. If you can know where they've moved to and pass on that information to your colleagues, then they can check and make sure that they're settling into the new facility in a way that's protecting their well-being, and even just checking on, did you get all your belongings, and then helping them follow up in case they didn't. So the role of the Ombudsman program in closures, it really is about making sure that residents' rights are protected and supported. And all of this work is very consistent with your role as just being an ombudsman, to ensure that other people are doing their job throughout this whole process and not to do the job. You shouldn't be packing people's belongings up. You shouldn't be driving residents someplace or coordinating their transitions. They're moving to a new facility. Your job is to make sure that the people who are supposed to be doing those things are doing them. And then if you ever have any questions about your role, absolutely, you should be asking your supervisor or the state ombudsman. On the Ombudsman Resource Center website, we do have under the issues tab, under in for nursing home closures, there are examples of resources from states, and there are little booklets. The one I'm showing here is from Kentucky, but there are several states that also have put together information. This one is for residents. There's some states have put together information for their representatives. I will mention at this time that tomorrow, on April 26th, we will continue this conversation about nursing home closures during our open office hours. And we'll be hearing from California, which has put together information for their representatives, and it works together with a relocation team. Hope that you will join us for that, so that we can hear your experiences, tidbits that you might have that would help other people have a safe and secure transition while working with the nursing home closure. This time, I'm going to turn things over to Lori Smetanka.
Thanks, Carol, and thanks, Amanda, for your parts of the presentation. Next slide, please, Carol. So the issue of closures has been a troubling one for a number of years. And several years ago, Consumer Voice did a multi-year project that was funded by the Retirement Research Foundation, where we looked at closures in nursing homes. And the goals were to really dig into what were some of the obstacles related to what we call a successful closure. And I'm going to use, quotes for that, because no one wants to see a nursing home close or have residents be forced to move. But when we talked about successful transitions, meaning that residents were given choice and were able to move to a location that they wanted, that it was done in a way that was not traumatic for them, or was any type of, it wasn't a chaotic move, that they were supported in the transition. So that's what we talk about when we were talking about successful closures or transitions. But we wanted to identify what were some of the obstacles to that, looked at what some strategies were for overcoming those obstacles, identify some best practices, and to make some recommendations that could be used for advocacy at various levels. Next slide, please. We heard a lot from ombudsman programs, from residents and families. As part of the our study, we did online surveys with all of the stakeholders involved, including ombudsman, residents and families, other advocates, surveyors, licensing agencies, facilities themselves. And we had a range of different comments that people would share with us with respect to the different closures that they were experiencing. And almost all of them were chaotic in nature. It talked about how there was no planning, the communication was terrible, the oversight was not good, the whole process was not good. And it really wasn't surprising that we were hearing about how unsuccessful these transitions were, and how people really were experiencing so many of the traumatic experiences that were placed before them with having to move. Next slide, please. Because nobody wants to move, right? Unless it's your choice and you're looking forward to going someplace of your choosing. But a number of the obstacles that were raised by the folks that responded to our surveys, and also some interviews that we had done with all of the different stakeholders, included lack of appropriate and nearby placements. And Amanda mentioned that, and some of you who are writing in the chat and the questions are also mentioning that as well, that people are having to move hours away to different counties, sometimes to different states, but away from their families and communities. Another obstacle was poor discharge planning that was happening at the facility, that the facility was not taking responsibility for that, and it wasn't being enforced, and it was all being done in a chaotic manner. Lack of communication with residents and families was huge. They didn't know what was happening. They weren't getting proper information. They weren't being informed of choices or different opportunities, and that created and not only fear among the residents and family members, but it contributed to the traumatic experiences and the chaos that was occurring as well. And also lack of communication with staff. That was a big one too. Carol and Amanda mentioned the impact on staff as well for people, who are losing their jobs. The lack of communication with them was also really critical. Poor notice to residents and families. They were not, too many facilities are not following the notice requirements as they're laid out in federal or state rules. And that was really problematic, and they were not being held accountable for that. The staffing issues, where as soon as people did know that a facility was closing, they were moving on to other places, trying to secure jobs in their communities because they did not want to have any not have any overlap and lose income, and that was really critical for them. And then also Carol talked about the transfer trauma that too many residents experience. Next slide, please. We also asked about best practices that were occurring in states, and the number one thing that really seemed to make a difference was that there were some level of coordination among the agencies and the programs that support residents in various ways, and that they were working together around the closure. And we're, for lack of a better term, we're calling it relocation teams or transition teams. Several of your states have developed them either formally or informally. We found that a formal process seemed to work a little bit better because there was more structure to it, there was more continuity to it. But having some sort of a relocation team or having the agencies work together really was critical in terms of helping to reduce the chaotic experience that was happening all around. Meeting one-on-one with residents and families and ensuring that the communication was occurring. And that doesn't mean just Ombudsman, but the facility should be meeting regularly with families. The surveyors, the survey agencies, or members from the relocation team should be meeting regularly with residents and families to assess, what is happening. Is the plan being followed properly? And are they being given the choices that they need and having their needs met during this whole process? Part of the best practice for ensuring that residents' needs were met was also to follow up with them after transition. How's it going, in their new location? Did their belongings go with them? Do they have everything that they need? Are they receiving the care and services that they need in this new location? And for some, it was a good move for them, but for others it wasn't. And there are some residents who chose to move again because the initial location was not successful for them. But so following up is really important to help prevent and minimize the transfer trauma that occurred. And Carol mentioned a number of ways that you can do that. Supporting staff was really critical. What efforts were being made to encourage staff to stay as long as possible, and then to support them in finding new jobs so that they were not being left without resources for themselves and their families. And certainly you want to ensure that staff will stay as long as possible to help with that continuity of care and to support residents during the process. There needed to be good communication with the receiving facility or the receiving setting, as well as the closing facility or setting. They needed to be talking to each other about the residents or the individuals that would be moving from one location to the next, so that the receiving facility or setting was best prepared to meet the needs of that person, to ensure that any trauma or chaotic experience was minimized as much as possible. But that communication was really critical. You know, they should be talking about what the residents' needs are, what they're going over their care plans, talking about preferences, and including the residents and the families in that process. That was really important as a best practice. Permitting state action. This was one where there were some states that, you know, had different types of requirements in the state that gave them more authority than they may have had in others. For example, one state that we looked at wanted public hearings if a facility was going to voluntarily close, and they had to essentially make the case about why the facility should be closing. Were there other options to prevent closure, such as, you know, selling it or turning it over to someone else to own or operate, so that the residents would not have to close, but providing some additional authorities to states, and this would have to be done obviously at a state legislative or regulatory level in order to have greater authority to ensure that closures were being done in a way that benefited residents. And then also ensuring that residents had choice and wherever it was that they were going to be moving. Next slide, please. So we developed a report that is available on the Consumer Voice website on our issue page, and I'll link to it a little bit later. But there's a closure report where you can look at what we had talked about during this study and some of our findings. We talked with a number of states. We even went in different iterations of the project and went and worked with states. We talked to those who seemed to be doing maybe more proactive work or had better systems in place for dealing with closures when they existed in the facility. We gathered a lot of information, and we developed sets of recommendations for CMS, for state agencies, and for ombudsman programs to help improve policies and procedures or guidance, to focus on training of staff and volunteers and those who are involved in the process, and to address some of the obstacles that exist for successful transitions. And if you look at the report, you can look at the various sets of recommendations and pull out pieces that might make sense for your state that you can advocate around to better have the closure process moving forward. Next slide, please. We also wanted to develop a toolkit of resources with samples and templates and checklists and sample letters and forms that could be used by other states and programs that were still in the early stages of developing their systems or their resources that they could use during the closure process. There's a whole range of them from a variety of states that you could pull from, where we do actually have letters that ombudsman programs shared with residents and family members, for example, or that were developed as part of the process that they were using, and they can be downloaded and adapted for your own state, for checklists that were being used and instructions for programs as they're going in and dealing with the closures, and even working examples of closure manuals that states have developed, or processes for relocation teams and what the roles of each of the different agencies were. So there's a whole list of information that's divided out by different types of sources that you can download from the Consumer Voice website. Next slide, please. We had also taken a few of the obstacles and developed some issue briefs around them, where we included and kind of not dug into the issue a little bit more, but wanted to send out to the states encouragement to tackle some of the obstacles in meaningful ways and take action where they could address some of these issues and work together to ensure that closures did not have to be chaotic in the state, that they could be addressed in a structured way that would meet the needs of residents and ensure that that their needs were being met, and that that it was not being done just in a haphazard way. And so one of the briefs that we shared, and they'll also be on the Consumer Voice website. But again, when we talk about relocation team, we dug into that in the report a little bit more. We dug into it in the issue brief. But essentially, this was, as I said earlier, one of the most important mechanisms that are being used right now in a state to address closures. And when we talk about all relevant agencies, and Carol mentioned this in her presentation, you need to have everybody involved who may have some level of engagement or interaction with an individual who lives in a long-term care facility. And that includes like the Medicaid agency and mental health and disability rights, the licensure agency. Money follows the person, so that you could have everybody who touches upon them, because what the states who are doing this found was that people bringing different resources ensured that residents' needs were being met, that they were ensuring that they were accessing all of the benefits that they needed, and also that they were moving to places that really did meet their needs and that they may want to move to. So for example, when a nursing home closes, that doesn't mean that every nursing home resident is going to go to another nursing home. There are some that may be able to move to a community setting or to go back home with supports. And so by involving the different agencies that work with helping to transition people to different locations, that provide support in home and community-based settings, you can ensure that people are moving to the setting that is most appropriate for them. And by including, people, the mental health or agencies that deal with mental health or mental illness, you also can ensure that people are receiving access to services that they may need, and that may transition with them to different settings. It's really important to clarify and understand each agency or program's role and developing communication processes. Talking about how the coordination is going to happen with services was also really critically important. And having a relocation team ensures that it's more than just the ombudsman who's on site, who's monitoring the process, because every one of these agencies has a stake in ensuring that these closures happen smoothly, that residents' needs are being met, because otherwise they're just going to pop up in the system in different ways. And when you have trauma that's happening, the more you can prevent that, the more you can ensure that you're not going to be putting people in situations that are troubling for them. Next slide, please, Carol. Another one of the areas where we looked at recommendations, both for CMS and for the state, and I think, for ombudsman programs as well, is to really push for proactive action at the state level to ensure that residents are being helped as much as possible. And some of the examples that we heard of from states that were doing work in this area and that were listed as best practices and recommendations that should be adopted if they're not already adopted, is to really focus on pushing for those facilities, those settings that have available beds, that have open beds, that to make it so that they're open and accessible to all residents. Because we all know that there are some residents that have an easier time moving than others. There are some that may have more challenging diagnoses or heavier care needs, or more challenging issues that are being dealt with, that are very difficult to find settings for that will accept them. And so some of the things that were recommended, including establishing real-time lists of open beds in the community, and having that updated on a daily basis and making it accessible to the relocation team, so that you could look at every facility that has open beds and be, working with them to talk with them about transitioning residents, requiring nursing homes with vacancies to explain why they can't care for a resident. If a nursing home is certified at a certain level, another nursing home should be able to also provide care for any resident living in that setting if they don't have any special care needs that the nursing home doesn't provide. If they're certified and licensed in the same way, they should be able to provide the same level of service that the resident needs. And so asking, what are the barriers to you taking this individual person. Sometimes it was as simple as, well, we don't have the necessary equipment that we would need to care for that person. And we heard about, like, for bariatric residents, for example, we don't have the wheelchairs or the beds or, you know, whatever it might be, the lifts that we need. Well, why can't the equipment from the closing facility go with the resident to the new facility? You know, find creative solutions to the transition to help encourage facilities to accept another resident, ensuring also that medical records were up to date and that facilities were doing in-person interviews with residents. That was important, because if they're just looking at the medical records, too often they were out of date, and facilities, potential placement facilities were not getting the best information about the individual, and were making decisions about them without having accurate information. Next slide, please. So we have a lot of resources on the Consumer Voice website. I would suggest you go there. We have a toolkit that you can, there's a web version and a PDF version, and you can just go and download the resources that are there, and certainly reach out to us if you have additional questions or need more information. So with that, I'll turn it over to Pam.
Thanks, Lori. Great information. Thank you. So I'm Pam with the Ombudsman's office in Iowa, just here to talk a little bit about the local ombudsman's role. Can we go to the next slide, please? So in Iowa, just to kind of give you an update, we've had 37 closures probably within the past year and a half. So that's a lot for us. And we've seen them along a variety of care levels, like nursing facility, residential care communities. So we've kind of seen the gamut. And we're finding that many closures are usually due to financial issues or lack of staff, unfortunately. And it seems to not all places, although they're required to do the 60-day notice, some of these closures are happening very quickly and often without much notice. So for example, one included an evacuation that had to occur within 48 hours. And at the time they claimed, oh, it's not a closure, it's just a transfer of the residents temporarily. So they all transferred out to the sister facilities. And what do you know, later they decided, oh, we're going to stay permanently closed. So we never really know what kind of a situation that we're going to be seeing as far as these closures go. So we do just try to stay prepared. And I love how Lori talked a little bit about like the crisis teams, relocation teams. We kind of have partnered with other state offices here in Iowa to develop a closure manual. And again, just a guide for each organization to kind of know what their role should be within these closures. And that has been helpful, you know, with staff turnover and stuff like that. And just for communication purposes, it's great to know kind of who is responsible for what and who we can reach out to when we need support, or if we've got some difficult placements going on. What we're seeing trending in Iowa is facilities going into receiverships. And that's when like a management company might step in due to like an emergency. So we'll say maybe the facility is operating in the red and they need someone to come in and try to get them back on track so they don't have to close. Or it could be something a little more urgent, like, oh my gosh, it's Wednesday and we can't make payroll on Friday. So receiverships are happening for different reasons. And generally, they are paid for by the facility or by the owner, unless it's otherwise ordered by a court. And for example, we've had a recent receivership where CMP funds, the civil money penalty funds, were used as the primary payer. As the use of funds, this is a use of funds that CMS would allow. CMS allows just for certain things to be paid for with these CMP funds, but they were able to float the facility and continue operations until everybody found a place. Within this receivership, an assisted living was one of the facilities that was closing. And because of the definition and the ways that money could be used, it could not reimburse any of the assisted living tenants for their deposits. So that kind of created a wrinkle, you know, as you're moving in, you need that money for a deposit for a new place. And that was kind of an extra challenge that we ran into, but something that we have on our list to eventually address legislatively. Next slide, please. So as far as the role of an ombudsman, I think we've pretty much been through that with all the other slides here too. Pretty much just do what you're doing, be an advocate, be there for the residents. I think it's helpful too to make connections with staff, talk to them, get a sense of who's going to be hanging out, who's going to be in it for the long haul, who's thinking about getting out next week or not coming back to work. So you can kind of, it's helpful too, because as you develop these rapport with some of the staff, they'll come up and say, hey, Mr. Smith's having a really hard time. Would you be sure to talk to him? Or sometimes they would, share concerns that they have personally about some of the residents or who needs support, or maybe who might be kind of feeling the pressure from staff to go to a sister facility, for example. So kind of gives you a heads up too on who you need to be keeping an eye out on. Next slide, please. So what does a long-term care ombudsman do after receiving a closure notice? So a lot of the stuff you already know. Make sure the state ombudsman knows. Reach out to your volunteer if you have one who covers that facility. Make sure the regulatory agency knows that you are the person in charge of the closure, so that way you can be on all the email chains, all the call lists, all that stuff. Just get on that distro list so you can keep in the loop. Reach out to the facility administrator and, talk to them about how they're notifying the families and the residents. Might be a great time too to say, oh, are you thinking about having a closure meeting? So usually this is like the first, usually within like a couple of days after the big word comes out about, oh, we're closing. Having a meeting with the families and the residents to kind of go through, hey, this is what's happening, and so forth is really a helpful thing to have happen. So talk to them about that, lay the groundwork for that. And it's also a good chance to discuss security measures. It's probably not a good idea to have other facilities just coming in, doing some resident shopping, saying, oh, we'll take 10 residents, please. So it doesn't work like that. Referrals should be made appropriately, and facilities should only be coming in if they've been invited and they have a referral. I think we kind of mentioned before, or Lori had that great idea for some sort of a mechanism to track real-time availability for beds. Like, oh my gosh, that'd be so cool. Well, we don't have that in Iowa. So we usually encourage the facility to reach out to facilities surrounding maybe 100 miles or so, put together a list of facilities that have available beds, how many beds, maybe if they have any specialties like we can accommodate bariatric or ventilators, or we allow smoking. That was a big thing in Iowa. Not every place allows for smoking. So having that kind of a list, having that printed out in a hard copy to hand out to the residents or the families at the meeting is super helpful. Next slide, please. So at these closure meetings, usually it's an opportunity for like the regulatory people. They might be on the phone or be in person. They kind of outline the process. The facility talks. They kind of say, oh, go to so-and-so with referrals, go to, kind of outline who's doing what. So again, that communication piece is important so that families and residents know who to go to, but it's a great opportunity to introduce yourself, hand out business cards, make a connection, let the residents and the tenants, families, everybody know who you are. I can talk to you if you're having a hard time or if you feel like you don't have any choices, we're here to help. So sometimes these meetings can be very emotional and tensions are high. So circulating, of course, throughout the meeting or even afterwards would be just a really great opportunity to make some connections and maybe kind of lower the tensions a little bit, do what you can to make sure that people know that you're there and that they do have support. Next slide, please. So for your initial visit, I've got kind of a checklist and I gave it to Carol. So I'm sure she's going to disperse it somehow after this presentation or maybe on the website. She'll clarify, but as far as like information gathering, I have a whole list, so don't feel like you need to take notes. Carol will pass out the resource list, but face sheets is important. It's nice to know who's on Medicaid, who's private pay, who has a decision maker, who doesn't. It's just helpful too for follow-up purposes. Getting information on the current census and keeping on top of that, whether it's like a weekly update or a daily update. Finding out special needs, any sex offenders, anybody with committals, anyone with like caseworkers or mental health advocates, or who can we refer to MFP, money follows a person. Let's get ahead of any referrals that might take some time or any referrals that we think are going to be challenging ones. So getting ahead of things really helps. Next slide, please. Okay, to-dos, perfect. So of course, to-dos would include participating in closure crisis meetings. You know, if maybe you've got 2 weeks left of your closure and you have 5 residents who haven't had placements yet. So, you know, getting on top of that, maybe having a powwow to discuss, you know, this person's really difficult. Let's pull in this person, use the resources. I think we talked about that earlier. Use as many as you can. And just do the regular stuff that we normally do. Make sure, you know, needs are being met, activities are happening. You know, resident rights are still being upheld and people are being treated with dignity and respect. And yes, it's a very stressful time, but that doesn't mean that the facility can stop doing what they're supposed to be doing. So just helping to monitor, sometimes partnering with the regulatory agency would be a good idea, especially if there are concerns about finances and like not making, getting the bills paid, kind of like Amanda said, or not making sure they had enough food or supplies, stuff like that. We can certainly keep on top of that and help with that. Next slide, please. So ensure the facility has plans for packing. We kind of talked about that earlier. Making sure that they have boxes, hopefully not garbage bags, because that's kind of not so great, but ensuring that inventory lists are happening, that they're being correlated with what they had before, what they have now, so that they can maybe search for any missing items before someone leaves. Transportation plans, we've seen a variety of options. You know, sometimes the Medicaid programs offer transportation. Sometimes the facility has a bus. In one of my situations, there was a resident who had dementia. He was pretty able physically, and they had to have someone ride with him in the back seat, and a staff person had to drive him because we couldn't find transportation. But it was like a 3-hour one-way trip, so it was kind of a long day for everybody, but they really needed that extra person in the back seat just to make sure he wasn't going to try to get out of the car or hit the driver, things like that. So sometimes you just have to be proactive and think ahead and make plans, and thankfully the staff were able to make that happen for him. Medications is another one, especially for people who have like VA bulk medications, making sure that those are going with the resident when they leave. Oh, resident trust funds. You know, you always want to make sure, if possible, on the day that they're leaving, if they could get their trust funds that day, it really helps get rid of any further issues with that. Also, I would suggest to having a corporate contact in case after the closure, someone's waiting for a refund and it's been over 30 days. It's good to have a contact in your back pocket. So if you do need to do some follow-up work on that, you've got someone to contact. Next slide, please. So after the closure, I know Lori mentioned making follow-up visits. I think that's great to identify transfer trauma, you know, find out who's thriving. I mean, unfortunately it happens, but people suddenly pass away, and that's always the heartbreaking stuff. But if you can make a visit, great. Or if you've got a coworker in a different region who can make one, I think it's just great to lay eyes on people and make sure they got their stuff, their room set up, and hopefully their stuff just isn't sitting in boxes and it's not unpacked. Hopefully they will have kind of settled into their new routine. So I do have a checklist too, kind of a list of questions to ask when you're following up with someone. And I gave that information to Carol too to disperse. If you don't have time for a visit, reaching out to the responsible party might also be a nice follow-up option if that's more convenient. Just some kind of a touch base, I think, is helpful. And for tracking purposes, I don't know if internally you want to keep some kind of a document, but you know, maybe put in some notes somewhere in a shared area where you can monitor whether transfer trauma is happening. So if you would use that data, this might be a good time to collect it. Next slide, please. So a couple parting thoughts, just have a plan. Kind of go in with your checklist. It might be a quick closure. It might be the 60-day. You just never know what you're walking into, but just have your checklist, be prepared. Do what you do, be a great advocate, and do what's best for the residents and help them out, make sure that they're supported, and feel free to use any of the resources that I shared with Carol, and I'm sure she will share with everyone else. Next slide, please. And here's my information if anybody has any questions, and thanks for the opportunity.
Pam, thank you so much. Lori, thank you. Amanda, thank you. We've got about 10 minutes to answer some questions, so we'll jump right into that. If you guys want to all unmute, and yeah. So the first question, the first question is, how many facilities changed from S&F to rehab facilities? Lori, do you have any idea? I mean, I know I know that's been occurring in some parts of the country, but I don't have any idea how many we're talking about.
Yeah, unfortunately, I don't know, Carol. I have been hearing that it is happening as well, but we haven't dug in and looked at numbers.
Okay. And then for Pam and Amanda, how often did you, and I think you both kind of mentioned this, but how often did you go out to the facility or have someone from the Ombudsman be on site during a closure?
You want to go first, Amanda?
I can. So for us, as soon as we were notified that they were closing, we had, at least someone, usually more than one person, at least daily, 7 days a week. And oftentimes we ended up being there more than once a day, because, people would call and they'd have questions, or something would be going on, or, just various things that would call us to the facility. But, I'd at least once daily, 7 days a week once it started.
I would not say that's the same in Iowa. We only have 7 full-time staff for a whole state. So we don't have the bandwidth to do that as much as I wish that we could, but we kind of take it on a case-by-case basis. If it's a facility that's really struggling, we'll try to be there a couple times a week. But it just kind of depends too. It also depends too on how much support we get from our state regulating agencies. Sometimes there are closures when they don't pop in at all. So it kind of depends on that.
Okay, thank you. This one isn't really a question and more of a comment, but that finding that residents have, excuse me, moved from a personal care home to a nursing home when they really won't qualify to be there. And I think that goes back to things that all three of you guys mentioned, was, the discharge planning process probably wasn't followed, and somebody's just pushing people out the door. They're not being given enough information. Does anybody want to address this issue anymore?
No, I think that's right, Carol. And I think that's why it's important that the planning process be monitored right from the very beginning, just for that very reason.
Okay.
One with all of and Amanda, I'm sure you're the same way, but I mean, we get routine census updates. So I'm always looking at the list. And if there is someone who's in an assisted living right now and they're going to nursing home, I want to make sure, it's not just convenience, just because they're on Medicaid, it doesn't mean they have to go to the nursing home. So making sure that that person's okay with it, that they actually need that level of care, that would just cause me to ask some questions.
Absolutely. This is an opportunity when money follows the person or home relocation. This is the perfect opportunity for them to swoop in and move people back to a less restrictive setting. Does the CMS closure requirements regarding closure plans apply to PHC, PCCs, or just to skilled nursing?
They apply only to Medicare and Medicaid certified nursing homes. So closure requirements for the other types of personal care homes, as mentioned, you'd have to look at your state rules.
Okay. Another best practice comment that one program created office hours at the facility so that staff, so that residents and family members could drop in. Is that kind of what you guys were doing when you were there, or you just showed up and? Okay.
I was just popping in.
Yeah,
Okay.
I just showed up, I did the unannounced visits. And I think, sometimes unannounced visits work very well for us. Most of my people in personal care homes, there were very few that actually had family members. Many of them are under state guardianship. I did have a few that still had family members, and I would just communicate with them regularly. But again, most of my people were state guardianship.
Okay. And somebody asked about the closure manual being available. Absolutely. We're going to be putting all of the checklists and manuals that people have been mentioning on this will be on the website and will be included in the information that's sent out following this webinar with the recording. So you guys will all get all that. So who decides the facility needs to go into receivership?
So that's kind of an ownership decision from what I understand. Like if the owner is saying, oh, we need to do something, or we're going to have to close 6 months down the road, they might want to go through the receivership process, which is through the court. And at least it is in Iowa, and get someone appointed to kind of step in and do management, maybe from a broader scale or more on site, like having the corporate people coming in and kind of revamping policies and stuff.
I would also say that the licensing agency probably could, certainly for CMS, receivership or temporary management is a remedy that could be imposed in certain situations if necessary. And I would think at the state level, in many areas, that would be the same. So it would be probably one of the two, either Pam, as Pam saying, through the court process, the owners or the licensing agency.
Okay, and that just dovetails right into during a closure, how can the Ombudsman program hold the licensing agency accountable when they don't enforce too many other things that they're not accountable for?
That's a loaded question.
Yeah.
Yeah.
Well, and that's a big problem that we know happens all the time, right? Certainly, I think this is where also having, a relocation team is helpful, engaging the other agencies that are involved, I think would be important that, touch upon the resident. And frankly, if you have concerns about what your state licensing agency is doing, you need to refer or contact your CMS regional office location for assistance. If they want to know when licensing agencies are not doing what they should be doing in all situations, not just closures, but if you have concerns that the licensing agency is not doing its job, reach out to your regional office contact location for CMS.
Okay. So how does a local program balance all of the duties expected when a closure is happening? Thank goodness for programs that have volunteers, right? Because maybe you assign a couple of volunteers to that particular facility so that nobody has to be going out every day.
Well, and I would suggest, and I'm sure Pam and Amanda have additional things they could add, but certainly this is something that needs to be coordinated with your state ombudsman, your program supervisor, to look at, what your priority issues are, how you're going to meet them. Are there other resources that can be tapped in? For example, if you are spending some additional time in your area to provide support to closures, can maybe your ombudsman colleagues in neighboring regions provide some additional support in some fashion to your program? So this is where, coordination at the state ombudsman program level, having everybody engaged and involved and communicating with each other is critically important for figuring out how you're going to meet those needs.
Definitely.
Absolutely.
Yeah, we used to have when we had a whole bunch of closures happening at once, we'd have a weekly closure meeting just for us to give updates and say, oh, hey, I need some help over here. And that way, some of our program staff could pop over and offer some assistance.
Perfect. Well, at this point, I want to thank Pam, Amanda, and Lori, and the CV staff in the background, for this, and the information that you've provided. We didn't get to all the questions. We'll see if we can raise some of them tomorrow during the open office hour. Again, thank you all, and be watching for an email that will have the resources, the recording, and the other information that was mentioned or shared today. Thank you all, and have a great day.